The reason we are doing this is because every day folks are dealing with new pain that doesn't go away.
Pain's a difficult thing to understand, so let people know what kind of options they have.
Well, welcome back to the podcast that Dr. Powers and I, Scott Glazer, are producing to help patients and physicians understand the causes of pain and the treatments and the developments, not just the past couple of decades, but the past couple of years. And we call our podcast
Maximize Life Advances in Pain Treatment.
And if you want to Google it, what's the best way to Google it?
The best way to get to us is go to our website, painchicago.com. We're coming from pain specialists of Greater Chicago here in Burr Ridge, Illinois. Best way to get there is via that. We're on Spotify, Apple Podcasts, YouTube. Yep, okay. We're on YouTube. That's where you can see us. That's probably the best way to listen to our podcast because we're able to interact. You see the things that we're doing. You see our nice podcast studio that we've created,
and you see the cartoon that you created of us, the mountain man and the baby.
Oh, they get the cartoon no matter what, so that comes in all. Yeah.
I don't know about that. But today we wanted to move on in our treatment, in our discussion of some of the most common things that patients suffer. And we've been talking about, originally he's talking about some of the newer procedures, and we're going to go back to one of those procedures, Intercept, today. Then after we talked about some of the newer procedures to get everybody excited, we started talking about basic causes of pain and basic procedures that we perform, treating the facet joints, because that, again, is certainly the most common cause of pain and the easiest one for us to treat. Unfortunately, there's patients who don't get relief when we treat the facet joints, and they are suffering discogenic pain. Discogenic pain or vertebrogenic pain. They're suffering pain in the midline that's from the structures in front of the spinal canal. You want to go on from there?
Yeah. So a lot of people might just wonder, what is a disc? I've been told I got a disc problem. So when someone's referring to a disc in the back, they're referring to what's called an intervertebral disc. Inter meaning between, so between the vertebra. You got a bunch of bones in your back, and cushioning those bones, allowing for spinal flexibility, are kind of a jelly-like disc that exists between the spines of the bone. You have them between every single vertebra except for right at the tip top between your C1 and 2. Otherwise, from C2, 3 all the way down to your L5, S1, you have discs. In your sacrum, you don't have discs. Those are all fused. Some people have discs. I shouldn't say no one does, but some people have discs. So a disc it consists of two parts. There's one part that's called the annulus. That's the outside of it. It has like concentric rings, almost like a tree. It's
cartilage.
It's cartilaginous.
A type of cartilage.
It's primarily cartilaginous, and if you were to cut it and look at it, you'd see it has alternating rings to it. So you got fibers that run one way, you got fibers that run the other way, and why is that? Provides stability, and it creates a stronger structure. And then inside of that, you have something called the nucleus pulposus. That's jelly-like. That's in younger people. That could be up to like 90% water. So it's a bunch of things called proteoglycans.
Right.
Yeah. So
it holds water. And that's important because
it can pressurize the joint or pressure. It cushions. Yeah. So just like I don't know. I guess I'm trying to think of an example right now, but essentially distributes weight across the end plate of the vertebra of the vertebral body. So the large part of the spine. So the front part, large part.
I think that's important. When we talk about end plate, again, we talked about talking about the intercept procedure, but the end plates are the top and the bottom of the vertebra, and they're not just bone. The nutrients to the disc go through the end plate. The end plate's very much more complex than we used to think. We just used to think it was like bone, like a humerus, but it's much more than that. We'll talk more about that. But the important thing is if I don't, I'm going to interrupt you a little bit and add on to it. So when you're born, you have all this fluid in the center of your disc in the nucleus pulposus. And that's when you jump, stand, walk, just forces of gravity. That fluid in that nucleus pulposus, that's where the vertebra bounce up and down on, and all the forces sustained by that nucleus pulposus. But as one of the first sign of degeneration is losing the fluid content, and that can occur young if you have bad genetic makeup, or it can occur later in life. It also is affected by how active you are, what your job is, what your activities are. But that's the first degeneration, is you lose the fluid content. And so then, because it's not, the center of the disc is not cushioning the vertebra, all the weight of the vertebra, your body, all the weight goes onto the annulus. And then the annulus starts to wear down. And take it from there, please.
Yeah, and the annulus is actually, so the inner part of the disc, like you were saying, gets its nutrients by basically diffusing into the disc. So the discs don't really have a good blood supply to them
Correct.
at all, which is why they tend to degenerate over time. And the outside of the disc, it has nerves in it, things called the sinovertebral nerves. Yeah, the annulus. And actually, as you lose that nucleus pulposus, you end up getting more innervation to the disc. So that's where people can start to feel more discogenic pain. It's kind of a catch-22 or whatever you want to, however you want to call that.
It's just like a joint in your body. Once other joints in your body, is that they get degenerated, you have no pain. But then if there's an injury in addition to the degeneration, and the pain nerves are activated by that injury, because that's a warning sign. We were talking about that. Pain is a protective maneuver.
Mm-hmm.
You want to kind of hold your back still for a minute after you injure your back. But that pain, because it's cartilaginous, again, as we discussed, not enough stem cells come there to repair sometimes. Sometimes they do. Sometimes you have pain that goes away. But if you develop a chronic pain in the middle of your back from a disc injury to the annulus, so the pain nerves are activated, sometimes they never get better. And that's patients we end up seeing who have discogenic pain. Yeah. And you want to talk about the difference between discogenic pain and vertebrogenic pain?
Yeah, so they, both of these types of pains are kind of happening in a similar area. Vertebrogenic pain is us really identifying that a large portion of pain that's coming from degenerative discs are carried through pain fibers that are actually in the bone of the spine, the large bone, the vertebral body, and specifically carried by something called the basivertebral nerve. And that really starts to get affected when you get changes to the end plates of the vertebral body, so the tops and the bottoms. And how does that occur? I mean, you can get herniation of disc material through the end plate of the vertebral body, irritating the basivertebral nerve. The disc contents are very pro-inflammatory, so they're gonna tell the body that there's a problem when disc contents leak out. So that can happen with disc herniations,
right.
or also called like annular tears in some cases. But it's very irritating to the body. So when it gets into the bone, you end up with something called this vertebrogenic pain.
When you get inflammation, disruption or inflammation. Sometimes it's just inflammation of the end plates.
Yeah.
You see it on the MRI where this thing called modic changes, which is evidence of wear and tear of the actual end plate. But go ahead.
Yeah. And discogenic pain, you can have pain from the disc without having swelling in the vertebral body, because the discs themselves are also innervated by something called the sinovertebral nerve, which is basically a bunch of nerve endings that come off of like the first nerves that come off of your spinal cord. Some of them are redirected towards the disc. So if you have changes to the annulus or the outside of the disc, you can end up with kind of more discogenic pain. And typically, when you have damage to the annulus, it's going to happen in the back of the disc or the posterior part of the disc. That's the thinnest part of the annulus. If you think about how your body is positioned, it makes a little bit of sense. Most of your weight is in front of your spine. The majority of weight is in front of the spine. So your annulus in the front, the thick cartilaginous part that holds the jelly-like interior in, is thicker at the front. And it's thinner at the back. Well, if it's thinner at the back and you have a lot of pressure inside of that disc for whatever reason, could be an injury, could be just a lifetime of living, and you can get tears in that annulus, and they're typically going to happen at the back.
And just to I don't want people to be confused. Herniated disc issues can cause sciatica, can cause radicular pain. We're not talking about that. We're talking about disc. That's a separate issue, which we'll talk about.
Yeah.
We're talking about lower back pain that's confined to your lower back, where you have problems with your annulus. You may have a bulging disc. You may have a herniated disc, but you're not suffering sciatica. You're suffering back pain from that.
Yeah.
Because the annulus, the disc can't come back unless there's a disruption of the annulus, and that's what annular tears are. Sometimes you can see it on an MRI, sometimes you can't. If you see one, it's just more positive that's the cause of the pain. Let's talk about treatments of disc pain, or the lack thereof.
Yeah.
Go ahead.
So, do you want to talk about the history of treating disc pain?
Why don't you?
Well, because I don't do as much of the.
Because I've lived longer than you.
well, yeah. A lot of the previous treatments that we were doing for discs, like intradiscal injections and things like that, we just don't do as much of, I guess, anymore.
Unfortunately, the only treatments for pain that we can get approved these days are treatments that have a robust scientific evidence. Facet joint injections, nerve blocks, radiofrequency ablation, epidurals. Unfortunately, there has been many treatments for discogenic pain. People where you do facet joint injections, facet joint treatments for, and they don't get relief. It's midline. We do an epidural, they don't get relief. We used to have treatments for that, but the science is not as robust. There's not as many studies. People could still get better from them if we were allowed to do them to patients. We're just not allowed to do them anymore. One of the first was called intradiscal electrothermal annuloplasty, IDET, which involved putting a needle in the disc in the back on one side and then putting a device in. It was a steerable tubing that it would circle all the way around to the back of the disc. You'd position it against the back, the posterior annulus, and then you'd heat up the posterior annulus. So basically it's a heat treatment, just like, and you're heating up the nociceptors, i.e. the pain nerves, in the posterior annulus. It's the same way we treat facet joint pain. You're treating nerves that are carrying the pain. I helped a lot of patients with that procedure over the years. It used to be approved by Medicare. It hasn't been approved. I mean, again, because so many patients, because of relief, instead of 70% of patients, it was 50% of patients, insurance companies won't pay for it. And there's another procedure called biaculoplasty, which I've been doing for patients up until a month ago, when the company stopped making the device anymore because so few people are doing it anymore. Because biaculoplasty, which is another radiofrequency treatment for the back of the disc, where you put in two probes on either side of the disc and you create a radiofrequency current between them, heating up the back of the disc. Biaculoplasty is not approved by Medicare or Blue Cross Blue Shield. I only could do it on patients who had personal injury cases. And we're not having the insurance companies telling us what to do. I explained to the patient, this could help you. Your only other option at this point is back surgery. And I've had wonderful results with biaculoplasty. Not in every patient, but the majority of patients. But I can't do it except on those patients. And now I can't do it at all because they don't have that device anymore. We used to do steroid injections into the disc. We really don't get that approved anymore either. What is the
There are other like nucleus pulposus,
Yeah.
like replacement
Yeah, what's the name of that?
products out there. There's a few of them, and I'm blanking on them
And
right
they're
now.
not approved. I mean, they're self-pay,
Yeah.
and they don't have robust science behind them. So basically, what we're telling you, audience, is that it's hard to treat disc pain.
It is.
There aren't a lot of procedures. The ones that we do have aren't approved anymore, and that's why we hope everybody has mostly facet joint pain. Any other comments about that? I feel like I'm missing something here.
Yeah. I mean, we talked about Intercept for patients that do have end plate involvement, which a lot of people do.
Well, and that's this is true. I mean, unfortunately, when you are younger, you're not going to have the end plate as a cause of pain, most likely.
Mm-hmm.
But someday they might show that not only is the sinovertebral nerve carrying the pain from the disc, but maybe somehow it's connected to the BVN. Maybe we'll start doing radiofrequency, the Intercept procedure inside the vertebra to treat disc pain. But I don't know when that'll be, and I'm probably wrong. There's probably not a connection. What else? I will say, this is interesting. A lot of our patients who have discogenic pain, who don't want to have a fusion surgery because so many people that are harmed by fusion surgery and made worse, there is one other option. And the big news is that Humana just approved this option. We can now do spinal cord stimulators for patients with Humana to control their lower back pain, even though they haven't had back surgery. This is huge for discogenic pain because you don't want to have surgery. That's crossing a bridge that you can't ever uncross. Mm-hmm. And what you want is pain relief. So you put a stimulator in a patient, keep their pain under control with the stimulator until something better is invented. Because you can see just by our conversations, things get invented. It's not uncommon. They'll hopefully invent a procedure or an injectate for disc pain in the near future. And so those patients who we put in stimulators, we can do that injection, their pain goes away, we take out the stimulator. At least that's the grand plan, right?
Yeah, that would be.
I think we've covered everything else, except we didn't really talk about disc pain in anywhere besides the lumbar spine. You can have disc pain in your neck. You can have pain in your thoracic spine. Even harder to treat.
Yeah.
Even harder to treat because when we do transfemoral epidurals now in the lower back for discogenic pain, if we do the approach, the Kamen trials approach, we're putting the needle right behind the disc. I mean, you're putting steroid right behind the disc. We can't do that approach in the cervical or the thoracic spine. Those patients are probably going to end up with spinal cord stimulators or peripheral nerve stimulators, don't you think?
Yeah, I think so. Yeah, probably spinal cord stimulators. Yep.
Well, you're recently trained. Am I missing anything, about disc pain that you learned that I haven't mentioned?
Unfortunately, I think we've talked about pretty much everything. So,
right.
but it is a huge focus. I think nowadays to find new treatments for it. So I think there's a lot on the horizon for it.
And I remembered what we forgot to talk about. So how do you diagnose disc pain? No matter how much time we've spent telling you guys that MRIs don't give us the answer, because people can have 5 degenerated discs and no pain, or they can have no degenerated disc and severe pain because they have an annular tear that you can't see on the MRI. So there is a gold standard for disc pain, and that's called discogram. Discography is what we're doing is we're actually stimulating the disc to see which one is causing pain, because normal discs don't cause pain when you stimulate it. And I like to explain to patients before we do a discogram, let's say that you had knuckle pain and I couldn't see very well, so I just started feeling your knuckles. I'd put some pressure on this knuckle. Is that the one that causes pain? No, it's pressure, but it doesn't cause pain. Put pressure on this one. It's the one that's got arthritis in it and pain and inflammation. Oh, yeah, that makes it worse when you press on it. Pressure makes pain worse. That's what we're doing with the discogram. We're pressurizing the discs to find out which discs are painful and which ones are not. Now, it's a very controversial procedure. You have to be well trained in it, and I hope to train you in it eventually. To do it right, it's part science, part art, because you've got to converse with the patient. You got to set their expectations so they understand what's going on, because it's not fun to have needles stuck in your disc to do this procedure, because we do have to put a needle on the disc. I can't reach in your body and squeeze the disc. And of course, there's some risk with it. There's always the risk of discitis, infection of the disc. We've discussed this. Our procedures are very safe, but there's this 1 in 100,000 or so risk of infection anytime you break the skin with a needle. But it does give us good information. I've been doing I still do discograms on personal injury patients. Again, it's not approved by the insurance companies. Discograms aren't anymore. They used to be. It gives us valuable information for patients. Those are the once we figure out which discs are causing the pain, those are the patients I can offer a biaxioplasty for. But I have surgeons sending me patients also for discograms to help them plan their surgery, which is what they, when we didn't have biaxioplasty and IDET, that's the only use of discograms, is to plan a surgery. You wouldn't do a discogram unless you had something you could do to help the disc that you found was causing the pain. So I think that covers it, dude.
Yeah.
Thank you again for setting up the studio and doing everything you did to make this podcast a reality, including the crazy mountain man and baby. I really appreciate it.
Yeah, definitely. Well, thanks everyone for joining us to talk about discogenic pain, intervertebral discs of the spine. Again, we're coming to you from Pain Specialists of Greater Chicago. Thanks, everyone, for joining us. We're going to be back. Hopefully, we'll be doing this on a more of a weekly basis.
Yeah, I think we will.
Is the goal. So we'll see everyone in the next episode. Thanks.
And, yeah, as far as next episodes, how about we talk a little bit more about radicular pain and radicular symptoms like neurogenic claudication, and just go over that all about epidurals and the different areas of the spine. And
we can kind of piggyback off of this and talk about the differences between disc bulges and protrusions and the difference between all those and prognosis for those as well.
All right. Thanks so much.
All right.
Appreciate it.